Hi everyone, my name is Adam Ballas. I'm with the Office of Health Services Research, School of Public Health, West Virginia University. This session is learning session number 6, CDEMS Analytics Advanced Topics. And for me, this is really a conversation starter into some work that we can do with your clinic, your health system, more one-on-one. And before I get started, I wanted to acknowledge the Pacific Chronic Disease Council for the fantastic efforts that continue to happen, and also Gwen Hosey for her leadership and expertise along the way. So our pledge of support, this can't be overstated. Our office remains available for support to you and your partners in any level of analysis that you happen to need, be it basic reporting on general use of CDEMS reporting, patient-level reports, summary reports using the reminder letters, call lists, etc., or more intermediate-level reporting, such as building new custom reports into your registry, figuring out how to use your data for run charts, figuring out how to display those data on storyboards or posters, or even write-ups that you may be interested in doing. And then also more complex issues, such as data quality analyses and cross-site analyses. And it's the data quality and the cross-site analyses that I wanted to take a closer look at, while also mentioning that run charts are something that we can also do together with you. The figure on the right-hand side of this slide represents, it's from an article that we published. There's a reference there on the link, but it represents an effort that we did with a smaller federally qualified health center called Roane County Family Healthcare. And in these sample data, we were displaying the number of diabetes patients each month and the average A1C per provider, and then the number of diabetes patients each month and the number of patients with 2 or more HbA1cs by provider relative to goals that that clinic had set for itself. So these are only sample data, but they do show our ability to produce practical tools based on partner needs and feedback. So this gave them, in a more automated way, the change in numbers and percent over time, month to month, in terms of these measures, plus other measures that this particular clinic was interested in doing. And there's a reference there, and I'd be glad to talk with any of you more about this type of run chart and what we might be able to do with your own data to be supportive along the way. But about data quality and the multi-site comparisons specifically, because those are topics that we're hearing come up here and there, and they're definitely worth addressing, at least getting that conversation started, as I mentioned a few moments ago. In terms of the data quality, there's a couple types of checks on the data that we can do with you. First, we can look at the data internal to CDEMS. So of all the data that you have about the patient's demographics, which is in table demo, their health conditions, which is in table health, their visits and vitals, which is in table visits, services that they're receiving in table services, other custom measures that you're tracking, which is in table measures. In each of those tables, we can take a look at, and also table labs for the laboratory values, we can take a look at how each of the variables are looking in terms of completeness, the consistency, if there's any outliers, and we can, in a more programmatic or systematic way, correct those issues and then give you back, or the end result would be a cleaned, updated data file that you can feel more confident about, feel better about when it comes time to do reporting from. So that's internal to the CDEMS data. We can do that together. And we can also use CDEMS to examine data that's not necessarily in CDEMS. So we've used the registry to look at data quality in electronic health records data and even other patient registry data such as PECs. So the reference we have here is an article that we wrote a few years back on a data quality check we did on electronic health records data in terms of whether or not you could easily or reliably use those data to identify patients that have high blood pressure. And what we found was that it was definitely a good idea to take a closer look at those EHR data, because it was very possible in this particular EHR, which was a certified EHR, it was very possible to free text the diagnoses into that system. So if you were to run a report of all patients by diagnosis, in this instance high blood pressure, you would get a relatively lower number of patients than was true, because due to some time issues and complexities and using that EHR and finding the right forms and the right fields to use, it was much easier for the providers just to simply go to a certain spot and type in the health condition rather than using the drop-down. So we needed to come up with a way of not just using CDEMS to validate the data, but using those reports, those data quality check reports, as an opportunity to have more discussions with those providers about what it was about the EHR that just was not working for them. So one small project morphed into a much larger effort, but it was worthwhile because for patient care and population health, you definitely need good, reliable data to go on. Now the multi-site comparisons, that's a pretty interesting, complex issue, but one that's worth looking at. We can analyze data from multiple clinics in at least a couple of ways. The first method's pretty straightforward. We can base a paper or a set of slides or a poster or a storyboard, whatever that venue might be, we can base that on summary reports that have been shared by each clinic. That's straightforward enough. I think that a lot of you, if not all of you, have already done things like that. That's great to get started. We can also do a cross-site analysis based on sharing of limited data files by each clinic. We have a supplemental learning session on creating those limited data sets using CDEMS, and that's something that I can definitely help with as you need it. But that method too is definitely worth looking at because it provides a lot more opportunity in not just making some initial statements about the data, but in more closely collaborating as a team around those data sets. And again, our opinion is that those multi-site comparisons are best handled using some data files, limited data files from each participating site. Some advice that we have: if you're going to do a cross-site or cross-clinic analysis, we would suggest that you keep it simple. So identify exactly what data you want to look at, because if you have multiple CDEMS data sets or PECS data sets or EHR data sets, whatever that might be, if you have all these data sets across various clinics, you're going to have a lot of information to try to digest, and it's much easier in the long run and more worthwhile, easier to talk through if those discussions are focused on one or two or three or four measures at the most, really. So if it's about diabetes, maybe across the board, you want to look at some very basic things for starters, such as how many patients with diabetes are we talking about? What's the age distribution of those patients? What comorbid conditions do they have? And maybe how many patients are actually coming in regularly to receive care. So that's an example off the top of my head in terms of what you could do, as a collaborative, as a PCDC collaborative, looking at all of your data all at once. And then based on those results, as a whole, you could look at your clinic relative to the group in an identified or an anonymous way. It doesn't have to be clinic named at all, but you could start to have some like larger collaborative level discussions on what some important topics are, how these topics are faring out across the board. And some questions that will definitely arise, things like, are all the necessary data collected across all the clinics? Is it being done consistently? Are there gaps in the data? And what outcomes can we really focus on? Those are all great questions. They'll likely come up, and they're all answerable with the actual data files, which is a sign of growth. Generally, for a lot of concurrent analyses on different data sets all at once, our office uses SAS for those sorts of analyses. So an advantage is that software is really built to handle more complex analyses across multiple data sets. A disadvantage is that software really requires programming expertise, and there's also a relatively high cost for it. It's not a free software. There's another way of doing multi-site comparisons of CDEMS data sets, and that's a tool called Grouper. Grouper was built from the Washington State Department of Health. So it's part of the original package of CDEMS apps, so to speak. An advantage, it's really relatively simple to use, and there's a lot of simplicity in its design. A disadvantage that I'm finding when I use it is that its original coding, in terms of how that tool works and how it sifts through the data, it's often expecting certain names for certain fields, which is okay. You just need to kind of know that in advance. But if it doesn't find those, the data sets that it creates in the end can be missing data. So as long as you know how to use it, it'll work fine. But if you don't know how it's going to behave, you'll likely end up with some problems. I just wanted to say that and be transparent about it, because that's something that I experienced myself when I started using that tool, and it just took me a while to get to know it, get to learn it, and know what its strengths and weaknesses were. But that's something that our office can help with. I would not want to presume that anybody is interested in starting from scratch. I know I sure would not be. So as you have need and want of learning how to analyze multiple data files all at the same time, which is awfully good for collaboration, we can help with that. And again, which brings me back to a point that I made earlier, our pledge of support. Our office does want to be very readily available to help you with basic, intermediate, and complex reporting. It's very worthwhile and fulfilling to talk with you all, to email, correspond with you. We learn a lot from you every time we talk. And the more we know, the more frequently we're able to talk or use Skype or whatever, the better off we are in terms of being able to be a partner, a real partner, and help you focus on those issues that you really need to have addressed. So please keep us in mind as these sorts of issues arise, whether it's something as simple as generating summary reports for your clinic, or learning more about doing run charts, which we can help with, or looking at multiple data sets all at the same time in different ways. Those are issues that we're very equipped to handle and are glad to do it. My email is listed here, abaus@hsc.wvu.edu. And as always, we'd love to hear from you, and we're very glad and honored to be working with you. So take care, and thank you.